Sim, tá. Muito obrigado. A gente vai falar em inglês, mas sim, eu gosto muito de português e estou muito agradecido do amigo Dr. Mara que pelo convite. Eu quero partilhar a minha experiência de pesquisa e de ter mudado do Peru até os Estados Unidos e espero finalizar um pouco cedo para poder falar, conversar. Se vocês tiverem alguma pergunta, alguma coisa, eu gostaria muito de ter uma conversa com vocês.
Ótimo. Então eu vou começar a introdução, tá? E aí, logo que eu terminar de falar, o Jorge já começa. Okay, my name is Alexandre Marra. I'm professor of Pós-graduação Stricto Sensu Program in Health Sciences at Albert Einstein Instituto Israelita de Ensino e Pesquisa, and also I am researcher at Hospital Israelita Albert Einstein. I've been doing research at the University of Iowa Internal Medicine Department in Iowa City, Iowa for 6 years. I'm really excited to introduce the fourth presentation in Einstein Connection series of guest speakers. Last December 2021 was the time of Professors Mario and Ricardo Venice and their students Felipe Bruno Oliveira and Larissa Zanetti with wonderful and inspiring thoughts. Einstein Connection is our international program that intends to connect Brazilian researchers, students, and healthcare personnel with international professors and international researchers. It's my pleasure to introduce our guest speaker, Dr. Jorge Salinas. He is the Assistant Professor of Medicine, Infectious Disease at the Stanford University. Dr. Salinas is also the Director, Hospital Epidemiology, Infection Prevention and Control Fellowship. He also serves as the Co-Medical Director, Infection Prevention and Control Program at Stanford Healthcare. I have been honored to have Jorge as one of my mentors at the University of Iowa, and it's been rewarding to collaborate with Jorge on a couple of research projects. He'll talk to us about from tuberculosis to SARS-CoV-2 study, navigating in different fields. We have planned for Dr. Salinas to speak for 45 minutes, after which we'll have a couple of minutes to answer the questions. You can unmute yourself and ask your questions after Jorge's talk, or you can type in your question in the chat. I'd like to ask for all of you to answer the survey at the end of the presentation. Thank you, and we now hand it over to Dr. Jorge Salinas to start. Jorge, please. Thank you very much.
Thank you very much, Dr. Mara, for the invitation. And this is going to be more of a casual conversation, and I want to walk you through my path towards where I'm at today, and a little bit less about scientific findings, but I will share a few examples of our research work over the years. So I'll begin, and thank you very much for being here. So I think everything starts. I am originally from Lima, Peru. I studied medicine. In Lima, and very similar to Brazil. I studied for 7 years. Did my internship there, but then I knew that I wanted to go to the United States. I had to undergo a number of tests, exams, etc., until I was able to transition to the University of Alabama at Birmingham. That was the first academic institution that opened its doors to me in the United States. I went there to do my internal medicine residency. There, I of course learned clinical medicine, but I received a mentorship. When I was in Peru, I had participated in research and started collecting some data, but I couldn't finish the projects because at that time I didn't have enough expertise on statistics, enough expertise on how to organize the research idea and how to present it. So at UAB, I had good mentors that helped me start organizing my thoughts, our research, our data, and supported me, for example, to go to Vancouver to present this data into the Infectious Diseases Society of America meeting. Eventually, again, with mentorship, and that was one of the key examples, early examples in my career. I had spent 2 years or so collecting data in Peru, but couldn't finish the project. After I went to UAB, there were mentors that knew how to do things and helped me finalize our projects. Oftentimes we study, we do certain things, but we cannot finish them. So that was something that I learned there, to take a project from the beginning until the end. So that resulted in a publication. Then I did another study with mentorship of friends from the University of Alabama that allowed me to travel back to Peru. So I started becoming again a global health researcher of sorts. Even though I was Peruvian, I was now living in the United States, but I was able to go back to Peru to review data and to analyze how using records of medication pickup, pharmacy records, we could predict whether somebody receiving antiretroviral therapy for HIV would be able to remain on that therapy for a long time or a shorter time. Again, another example of good mentorship. More so than the research idea is, for me, these were lessons on how to devise a project, organize it, travel, come back, gather the data, analyze it, finish it, publish it. So eventually I graduated after my 3 years of internal medicine residency. I had published a couple of papers. I became an internist, and I continued. In the United States, we do 3 years of internal medicine, and then there is usually another subspecialty that you could do. So I wanted to become an infectious diseases doctor. So one of the first lessons learned during my first 3 years of residency was that mentorship was exceedingly important. Associating myself with people that knew how to analyze data, how to write, how to present it. And also another big benefit of being in the United States was that the institutions support trainees. They not only taught me how to analyze, write, publish, but they also supported me to travel to go present my results. So that was very important. So my next step was my infectious diseases fellowship at Emory University in Atlanta. So I entered there. It was, again, another 2 or 3 years of clinical training to become an infectious diseases doctor. So there, these are my colleagues, infectious diseases fellows at Emory University. I learned, of course, clinical medicine, but I continued doing analysis, studies, learning more statistics. This was a very prolonged, complex analysis that we did, looking at HIV care metrics, viral loads, CD4 counts, in a cumulative fashion. We looked at the area under the curve of multiple measurements to see whether that was associated with both mortality and acute myocardial infarction. So this complex analysis was enough to be able to publish in a highly respectable journal with a very high impact factor of almost 10, Clinical Infectious Diseases. So again, another example of mentorship that gives you the opportunities to analyze data and to take it all the way until a publication. As in the 3rd year of my ID fellowship, I won a small grant to do a global health training that was sponsored by NIH, and that allowed me to travel to Manaus, Brazil, where I learned Portuguese. And I spent a few months at the Fundação de Medicina Tropical Heitor Vieira Dourado. There, I worked on a couple of things. We primarily collected samples of patients with malaria infection to do metabolomic analysis. I'm not going to go into all the details of this, but you use mass spectrometry to measure molecules that then you, by using very complex bioinformatics algorithms, you can determine whether there are metabolic differences in between groups with different phenotypes. Severe malaria versus not severe malaria, severe anemia versus not severe anemia, chloroquine resistance versus chloroquine susceptibility of Plasmodium vivax, for example. So we worked on that in Manaus, but there was something else that was very interesting that happened while I was in Manaus. In Manaus, I had a very small office that they very gently gave me, and several colleagues, several friends that were in training, masters, doctorate, etc., started approaching me to help them analyze other data that they had. So again, and I was able to participate in their studies that were fascinating studies that took us to sometimes visit communities and analyze malaria from different aspects and other neglected tropical diseases. So that partnership helped us in a short period of time, helped us to participate on a number of projects with these colleagues on doing systematic review analysis, looking at factors associated with malaria in children and micronutrient deficiencies, and also our metabolomic studies, looking at metabolic derangements among people with chloroquine resistance, severe anemia, and respiratory complications. Again, just some examples of several topics. One topic is that I wouldn't have published any of these things if I wasn't brave enough to go to Manaus. At that time, my daughter was 2 weeks old, and we had never been to Manaus, and we moved to to the Amazon with the baby, and but that took a lot of courage, but it was highly rewarding. It was a great time, great life experience, and it led to a number of great publications. For example, actually, there are two other publications that only happened because I was there. I helped them analyze some data, epidemiologic data, looking at spider bites and snake bites, for example. So again, and it even allowed me to participate of the carnival in Manaus. I had my own little carrinho. I participated there with my two. By then, she was a few months old daughter. So some lessons of this. I enjoy the statistics, but I of course I was learning by helping my colleagues, but I wanted to learn some more. I enjoy doing metabolomics work, but I wanted to learn more applied epidemiology, going to the field, working with communities. By then, I had accumulated 2 specialties: internal medicine and infectious diseases, and I was finally publishing more papers with more consistency. Emory, again, a good institution, had provided me with exposure to great mentors, great opportunities. So I think that was great, but even after those 6 years of training, I still wanted more. I had done some observational studies, I had done some basic science metabolomic studies, but after traveling, visiting the communities, I wanted to have a more practical involvement to improve the health of populations. So I was very fortunate to be able to enter a program at CDC called the Epidemic Intelligence Service. It's a 2-year training program that teaches you applied epidemiology. So they don't teach you how to do epidemiology. You do epidemiology applied to specific problems. So I'm going to show you a few examples of the things that I participated in. This was my class, the colleagues that I entered with, and this is very nice. And I'm pretty sure, I know for a fact that Brazil has a version of the Epidemic Intelligence Service in Brasilia. I'm blanking on the name, but Brazil has a robust one. I know for sure. I've seen many of their publications. And people that enter these programs are both physicians, pharmacists, nurses, veterinarians, and PhDs in epidemiology, for example. So public health needs people from multiple backgrounds. So there, I continue doing more sophisticated analysis, learning more statistics. I was able to do some studies looking at, for example, why is it that people do not complete their TB treatment for MDR tuberculosis? And again, a lot of emphasis on methods rather than just doing classic survival analysis. I was able to do competing risk regressions. I was able to do multiple imputations, multivariable analysis. So I was able to consolidate my statistical capabilities while being at CDC. And of course, that led to some publications. One of the great things about being at CDC is that it gave us access to national data. So I was able to analyze 20 years of data for every patient with multi-drug resistant tuberculosis in the United States, for example. And of course, data of that magnitude needs to be published in high impact journals. At the same time, after learning all those statistical skills, CDC presented me with other opportunities, the opportunities to evaluate public health programs. I was able to travel to multiple states within the United States and to other countries to assess how was TB care being provided. So this is a picture of us working in Kenya, evaluating their national tuberculosis program, for example. A picture again from the same trip. So again, that to me was very interesting, and that's what I appreciate the most of my training. I learned more statistics, but I started doing more applied epidemiology, going to the field, seeing how things were being done. And of course, after doing epidemiology or evaluations of surveillance programs, etc., we were able to publish some studies based on those surveillance programs. This is just an example of a publication in which we characterized cases of BCG-associated disease, people that got sick, either because they received a BCG vaccine, as we do in several developing countries in babies, or because people received BCG as part of treatment for bladder cancer. Another example of how we could do analysis using surveillance data, in which we showed that the proportion of TB cases among Hispanic individuals in prison in the United States has been growing up over the last 20 years. And another example of a good high impact publication that I was able to do here was this MMWR publication where we reported that the incidence of tuberculosis in the United States had stopped decreasing after 20 years of steady decreases. This this is another, small lesson that I can tell you. When I was learning analysis, statistics, and epidemiology, I thought that the best studies were studies that used very complex statistical modeling. In reality, my highest impact, the most cited publication I have is this one. And this one doesn't have one p-value. This publication only has n's and percentages, nothing else. But because, in other words, it's a descriptive study, but it's a descriptive study of data of such importance, the trends of tuberculosis in a country, that it allowed for this high impact publication. MMWR has an impact factor of 25 or so. So again, not always you have to do very complex statistical modeling. So something else that CDC again allowed me to do was again to travel, and this was another part of my training at CDC, which was outbreak response. This is a picture of a trip that we were doing in the coast of Colombia, where we and a group of colleagues investigated the association of Zika virus and Guillain-Barré syndrome. So our group published a number of papers using data from Colombia first, where we, along as other colleagues, of course, showed that Guillain-Barré syndrome was associated with a higher incidence, or that Zika virus disease was associated with a higher incidence of Guillain-Barré syndrome compared to the baseline incidence in the general population. We were also part of studies that looked at Guillain-Barré syndrome and Zika in Salvador, where we also showed how Guillain-Barré syndrome here in bars increased after a big wave of Zika virus infection in that area of Brazil. So again, all these opportunities, working on something that is novel, being able and brave to go after these opportunities, allowed us, for example, in this case, we were invited to give neurology ground rounds at Mass General Hospital at Harvard University. Again, as an example of how working on cutting edge research, especially associated with outbreaks, can have a very high impact. So, and that concluded my time at CDC. Here's a picture with the director of CDC. And so one of the, and my family. And so some of the lessons that I learned is that I really liked applied epidemiology. So knowing epidemiology, knowing statistics, knowing how to do a surveillance evaluation, knowing how to respond to an outbreak is what I wanted to do. That's my niche, that's my specialty. Yes, it uses statistical, analytical skills. They are needed, but soft skills, communication, persuasion, being able to present data to a scientific audience, to a lay audience, is still very, very important. To me, surveillance is the cornerstone of epidemiology, of applied epidemiology. You need to track in a consistent, methodical way, having predefined definitions, cases, events, etc. That allowed us to do a number of publications when I was at CDC. And something else that was very fulfilling for me is how to deal with an outbreak. An outbreak has to be managed and has to be investigated. So we learned to do those things during that training. So by then, I had worked for or had studied. I had been in training for 8 years. So it was my time to take on a full job. And my first job out of my 8 years of training was at the University of Iowa. I was very fortunate to be recruited to join the infectious diseases division at the University of Iowa to be their hospital epidemiologist. Interestingly, I had not worked on the prevention of healthcare-associated infections up until that point, but my training on applied epidemiology prepared me well for that role. So, as the leader of a program of hospital epidemiology, I had to work with multidisciplinary teams to try to solve complex problems in the healthcare setting. So we had to do quality improvement projects there. So again, it was a bit more on the field than abstracted, let's say, at CDC headquarters. We were in a hospital. It was very tangible. We wanted to help patients have better outcomes. Healthcare epidemiology, or being a hospital epidemiologist, allowed us to go everywhere in the hospital. We were part of evaluations of construction and renovation of sections of the hospital, because construction can be associated with risk of healthcare-associated infections, for example, fungal infections. We also participated in surgical site infection prevention, visiting the ORs, ensuring that patients were receiving the best care during those critical moments while they are having surgery. So all that was as part of my job in healthcare epidemiology at the University of Iowa before COVID. That allowed us to mentor trainees, have infectious diseases fellows, have international fellows that visited us, infection preventionists led efforts as well. And of course, that led to certain presentations at national meetings, etc. Also, while being there and being an epidemiologist, I was also approached, very similar to my time in Manaus, I was also approached by colleagues that had observations. They noticed that they were seeing more cases of this uncommon infection, Acanthamoeba keratitis. So again, we were able to apply our expertise on having a standardized definition and doing an epidemic curve, which are the initial steps of an outbreak investigation, that allowed us to confirm a growing trend of cases of Acanthamoeba keratitis in the state of Iowa. And that allowed us to have another high impact publication in Morbidity and Mortality Weekly Report at the official journal of CDC. And again, having a good team and having good surveillance in place allowed us to publish a number of efforts. And Professor Mara has been part of our studies during those projects as well. So my lessons up until that moment in healthcare epidemiology were that a diverse team, not only racially diverse, but also with diversity of experiences, of training, of backgrounds, was very, very important. Systematically recording data, even if initially that may appear trivial, can be very important. Once the data is accumulated over a long enough period, you can see trends. It's the only way of seeing trends. You have to systematically collect data. Consistently documenting these trends will help you uncover outbreaks that you may not notice otherwise. It is exceedingly important to have access to data, to information, and being able to analyze it. So knowing statistics is very important, but it's not enough. You need all of these things. You need to collect data consistently. You need to have a team that works well together. In Iowa, I think it was a dream team. We assembled a fantastic team of infection preventionists, doctors, students, fellows, visiting scholars from other countries that allowed us to do a number of studies that you couldn't do if you were missing any of those parts. So again, having a successful collaboration requires a number of things. People, number one, data, statistical skill are important. Then COVID came. And fortunately, because we had a good team and we had robust data systems, we were able to deploy measures and determine the impact of such measures. So this is a publication by one of our visiting scholars from Saudi Arabia that looked at our experience testing every person admitted to the hospital for COVID-19. So he was able to prove that out of, and this is data for just a few months, that out of nearly 90 patients with a positive test, nearly half of them had symptoms consistent with COVID, and the other half were not consistent with COVID symptoms. Among the people that didn't have COVID symptoms, another half of them, in fact, had just a positive test. They did not have an active infection. They were not infectious. Again, another practice that we implemented and were able to rapidly assess the impact and publish it and lead to high impact publications was a policy that we implemented of testing patients every 5 days. If they stayed in the hospital, we tested them every 5 days. That allowed us to demonstrate that 1% of people who have a negative test on admission develop a positive test afterwards, either because they were on the incubation period or because of in-hospital transmission from other patients, healthcare workers, or visitors. We investigated outbreaks there using classic epidemiology, what some people call shoe leather epidemiology, but also allowed us to use molecular techniques to confirm the pertinence to a cluster, or to rule out whether somebody was part of a cluster. Here, for example, in red, we have a cluster of cases that were in the same unit at the same time. But this person in green, even though was in the same unit and at the same time, had a virus that was genetically distant from the other samples. So again, even though classic epidemiology would have called this person in green as part of the red cluster, in reality was a result of community transmission. So again, we were able to, in a relatively short period, we were able to use molecular epidemiology to help us discern cases that were the result of in-hospital transmission versus community transmission. We were able to analyze and present our experience also at a programmatic level. And here we depicted the number of calls for COVID here in orange during the 2 peaks. One was the beginning of the pandemic, even though here in the dotted line, the number of cases wasn't that high, people were very concerned, and the number of calls grew very rapidly, asking for questions, protocols, etc. And the second peak was truly associated with the moment in which the number of cases went up. Another impact of the COVID pandemic on quality of care in our hospital at the time was that even though we had seen very nice trends in reduction of healthcare-associated infections, we lost a lot of ground after the COVID-19 pandemic for central line-associated bloodstream infections here on the left, catheter-associated urinary tract infections on the right, and a less pronounced impact on Clostridium difficile infection. I just left this here, but also, again, once our team was working well, we were able to do again, or to utilize some of those soft skills that I trained on at CDC, which is public speaking, how to convey information, public health information and action to the public. So since then, and since the pandemic, I've been part of innumerable interviews for television, radio, written media, etc. But that concluded my time at the University of Iowa. I had a fantastic team, again, multidisciplinary team with people that were MDs, PhDs, nurses, physicians, trainees from abroad, and trainees from the infectious diseases fellowship program. So again, this just highlights the importance of having a solid team. So assembling a diverse, well-functioning team is exceedingly important. Once more, we were very fortunate that by having robust surveillance systems, we were able to monitor the impact of our public health interventions, public health, but inside a hospital. Always, you can see these trends from before. You have to be curious. You have to go, if you think there's a problem in the operating room, you have to go to the operating room. You have to go to the roof of the hospital. You have to go wherever the problems are. You cannot be timid. Applied epidemiology is about getting your hands dirty, going to where the problems are, where things are happening. You have to have productive collaborators. Professor Mara is one of the most productive collaborators that I've had, and I'm very happy of having crossed paths with him. And there are people like that in life that are exceedingly productive, relentless, that are very methodical and accomplish their goals. Look for those people, collaborate with them. You need to have access to data, and you need to be able to analyze it, of course. And again, to me, even though I switched fields, HIV, tuberculosis, malaria, Zika, whenever I jumped from one field to the other, it just accumulated. The experiences that I had from before always helped me on the new venture. So when my time in Iowa finished, I was very fortunate to be recruited to join Stanford University to do the exact same job. Stanford University has recently built a $2 billion hospital that looks more like a hotel than a hospital. So this was me, in my first days at work in a fantastic place. This is a view of the hospital from outside, and here at Stanford, I've been here only for a few months, but we do have an infectious diseases fellowship, and we have a healthcare epidemiology fellowship, and our first fellow will join us starting July. And we have another fellow that will join us the next July, and we're going to continue having several fellows over the years. So I think I'm going to pause there, and thank you very much for your time and your attention. You can see my email there and my Twitter account. You can follow me there, and just feel free to send an email, and then of course we'll looking forward to having a conversation with Professor Mara and you all, and to answer your questions. Thank you.
Thank you, Jorge. Perfect. Wonderful talk. Very inspirational thoughts. It's very, very professional. And I like it very much because that's exactly what I expected in your talk. It's a very unique story, a successful story. And I'm sure that we will collaborate a lot in research projects with people from Einstein and from Stanford. And I will start with some questions, and I see that there is one in the chat. Roberta Grabert asked, Professor Salinas At the CDC, did you participate in the formulation of public policies?
Yeah, that is very interesting. I don't think that I personally participated on the formulation of public policies at the time. I think that perhaps my role had more to do with, at that moment, generation of data. For example, proving the association of Guillain-Barré syndrome with Zika, for example, or our analysis of the trends of tuberculosis in the United States. The data that we created, our analysis may have influenced policy, but I was not personally part of decision making at the national level. Interestingly, though, when I came to do public health in a smaller setting, which is a hospital, that's all we did. We in healthcare epidemiology, you implement policy every single day. You implement policy, you try new things. And that was a very nice aspect of the University of Iowa, that is a very fertile ground to implement, to innovate with policies, and allowed us to be some of the first people on do, for example, serial testing in hospitals and other institutions. I recall a colleague from one of the Harvard hospitals approached us, for example, wanting to see what we were doing. So again, yes, there are certain places where you can innovate, and oftentimes outbreaks, epidemics are moments where you have to move relatively fast and implement policies, but you need to be prepared to assess relatively rapidly what the impacts of those policies are.
Oh, wonderful. I have another comment here. João Renato is here. You know, João Renato, he worked with us in several research projects together in systematic reviews, meta-analysis about COVID-19 vaccine. João Renato is here, opening the screen. Do you want to ask any question for Jorge, João? You can unmute yourself. Okay. Or if anybody wants to ask questions, we can write in the chat. There is another question, Jorge. What do you think about our, in Brazil, the SUS, the public health system? What do you think about that and about the potentials for improvement?
Well, while I cannot comment on how well the surveillance system works in Brazil, what I can tell is that Brazil has very good surveillance data that can be used to do research and to inform policy based on that research. Public health is said to always be local. You cannot borrow data from other places, from other countries. You have to generate your own local data. In that sense, it's great that Brazil has robust surveillance systems. And I think that if anything, more research should be done utilizing those data that are collected for public health purposes. Some of the studies that I presented, I participated when I was in Manaus, had or used surveillance data. The spider bite studies, the snake bite studies had rich data that was collected for surveillance purposes, but allowed us to investigate, for example, and to prove that, for example, people that live several hours away from a place, from a hospital, for example, had poorer outcomes. So the time from the bite until they sought attention was an important predictor of severity of disease. So that has tremendous implications for policy. The antidotes need to be closer to communities. The study also allowed to figure out which areas of the huge Amazonas state had the most bites. So absolutely, I think that yeah, surveillance data, surveillance should always be done, and what we need to do is do more research using the data.
Great. And I loved it to hear that you said about the successful collaboration is first people. We have a lot of people here and a lot of students, fellows. And what is your availability to accept international fellows from Brazil in your department?
I think that they are welcomed. They are welcomed. I think that we would need to work on details, paperwork, visa aspects, etc. But absolutely, my experience collaborating with Brazilian colleagues has been phenomenal, and I don't think that I would be where I'm at if it wasn't because of my parcerias, my partnership with colleagues from Brazil. So absolutely, we can always look for ways to either partner from afar or to have people visit. Absolutely.
And are you open only for medical doctors or other healthcare workers? For example, nurses, pharmacists?
I think that, again, on a case-by-case basis, we could look into ways, but know that from a political point of view, sure, there is the will to help, to collaborate. So absolutely, we would perhaps through Professor Mara, we can have conversations and help people find the right place, the right time for visiting, for collaborating. But absolutely, I would love to continue doing that.
Yeah, I think, and I appreciate very much that you are available to accept international fellows. And for everybody that is in this room, and this talk is recorded, and you can see later, Jorge speaks very well Portuguese, and this is a great opportunity. A great opportunity. Of course, that if anybody wants to move to the United States for 1 year, 2 years, you need to learn to speak in English. But Jorge speaks Portuguese, and this makes a lot of difference because you can be more confident, and this transition is pretty difficult in the beginning when you move. And Jorge knows about that, from Peru to United States, or me from Brazil to United States. It's really helpful to have a mentor like Jorge with all his background in different fields, and with the same language that we are not talking here in Portuguese. We are talking in English to provoke you, but Jorge speaks very well Portuguese, and that's what I want to emphasize this. And I love your talk, and I love because of people. That's the first one, about the data, and this was really making the difference in COVID-19 pandemic. We need data, good data, to avoid the fake news and to have good research, and you proved it for us in your talk. And I see that after your medical college, medical residence, you want to know more, and you emphasize a lot about statistics, and I like very much about that. I want that you can talk a little bit more. How was the tracks that you recommend? Because now we have different pathways, we have different computational languages, we have machine learning, for example. And I think that for the medical students or students, fellows from the post-graduation program in Albert Einstein, sometimes it's very difficult, because I remember when I did my fellowship in 2000, I need to study SPSS or SAS or STATA, and now we needed to go to Python, to R, because of this heavy data. Could you talk a little bit about that?
Absolutely. So my experience may not necessarily be, you know, the way to go, but it worked for me. And my first real introduction to statistics wasn't too fancy. As part of this global health fellowship that I did in my third year at Emory, that allowed me to visit Manaus, we spent 1 week at NIH. And we received training on a number of things. And one of the trainings that we received in the afternoons was how to do some basic statistics using Stata. And even though I had tried many times to learn statistics, that was the first time that I felt that, yeah, this is doable. I can do this. I can load my data and do simple manipulations. And when I was in Manaus, I was still learning some statistics on my own. And my colleagues there approached me with their projects. And I just jumped and started trying. And I started coding more and more and more. Stata was a very approachable software. It wasn't that difficult. SAS is also relatively easy to code on. Now, R is exceedingly capable. And however, at the beginning, it can be intimidating to several people. So we have to be very, very astute on the way that people are introduced to statistics, introduced to R, for example. I think this guy called Hadley, I think is his name. He writes these books about R, and he calls it the tidyverse. And he's creating ways of coding that are a little bit easier, more user-friendly. And he starts teaching R, for example, with ggplot, with visualization. So again, in general terms, depending on the levels of statistical knowledge of our colleagues, I would encourage people to start in the simplest, easiest way. Start small and go from there. I think that if our colleagues master how to do data cleaning, just cleaning the data, and descriptive statistics, that will take you far, 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 far. My most complex statistical analysis have been very easy to code. The hardest part is to clean the data, to put it in the right format. It's also very important, besides learning how to code, learning how to enter data into databases. That is very, very important. The creation of databases, for example, to not record continuous variables as categorical or dichotomous variables. Let's say, for example, somebody may say fever. Okay, fever, yes or no. Don't do that. Document the temperature. Then you can code whether the patient has fever or not, and you can have different thresholds of fever if you want to. Same as age. Sometimes people enter the age, the numeric age. I usually go for date of birth, if it's allowable, because then you can do the calculations. Maybe I want to know what their age was 5 years ago, etc. So it allows, again, try to document raw data in the simplest way. Continuous always wins over categorical data. And not everything has to be, for example, in one table with one row, one observation per patient. Oftentimes, data is going to be complex, and you're going to have something called panel data. Let's say 5 rows for each patient. And that's what you need to learn, how to, using the software that works best for you, how to converge, if you will, the 5 rows into 1 row for one analysis, or different rows for other analysis. But again, just data cleaning manipulation. In R, people call that data wrangling, and being able to do descriptive statistics. To me, you already passed the test if you're able to do that. If your data is clean, you will be able to do machine learning. You will be able to do complex survival analysis, multiple imputations. That part, again, programmatically is not difficult. It's cleaning the data. That's what we need to spend the most time on.
Wonderful. We have 4 minutes, and we have some comments in the chat saying, thank you, Jorge, for your participation here. And other 2 comments saying, oh, I want to go to Stanford.
Absolutely.
You convinced them.
Yes, so Stanford is a terrific place, a great university in a great part of the country. Very beautiful. Almost there's no winter. It's a great place. Great opportunities. Lots of things to do. So, of course, under the orientation of Professor Mara, would be happy to discuss with people that would be interested in exploring how to achieve this.
Oh, thank you very much. And as I told you before, when we start this conversation today, I think that next month we will start in the post-graduation program, scientific methods for the fellows. And I invite you to participate in our Zoom sessions, and you can talk more about data and about some methods like you are more familiar, like observation studies, and whatever to talk your experience at CDC. I think that will be very, very helpful and thoughtful for all of us. And maybe I think so that we can string our connections between you and people from Albert Einstein, like João Renato from the microlab doing the whole genome sequences in SARS-CoV-2. And I really appreciate Jorge. Thank you very much for being with us in São Paulo, Brazil. And I hope to invite you in a lot of other talks. Thank you.
Muito obrigado.
Everybody.
Muito obrigado.
Muito obrigado a todos. Muito obrigado, Jorge. Um abração. Até logo.